Hello, everybody. I'm Amanda Goltz, visiting here from San Francisco, California, where nobody is awake yet. But I'm very grateful and appreciative to be here. First, I want to thank Patrick for hosting us all at Stockholm Sun, for Donnie, your amazing emceeing abilities, and Dina as well, and then for Nima for bringing us all together. Such an amazing, curated set of entrepreneurs and speakers about healthcare, so thank you. So what am I talking about today? I'm going to go back to my title. So this is making a little joke. You know, the best thing to do about something that's distressing is to make a joke about it. So the healthcare system in the U.S. needs a little bit of work. I like to look at it as a curse. May you live in interesting times, and times certainly are interesting. Here's what you need to know about me. I have indeed, as Donnie mentioned, been on all sides of the healthcare system as we have it in the U.S. The private health insurer side, I worked for Aetna, soon to be, hopefully, the second largest private insurance plan in the United States. I worked for the state of California on a public initiative to build health information exchange. I've worked on the side of the purchasers of healthcare, the big employers who buy health insurance for their employees. More on that in a moment. And I have also worked in some other roles inside of a provider system, inside a hospital and a doctor, or a place where doctors work. I have never been inside of a doctor. The things that I have learned by doing that are all the different perspectives about the healthcare system, where certain things fall into the cracks, and how the fragmentation creates opportunity for really great problem solvers. And that's what I want to talk to you about today. I don't want to just give a history of the United States healthcare system. I want to talk about where smart entrepreneurs and people with very agile companies can deliver solutions to make this all work better. And the last thing you need to know about me is that I've tried to do this myself. I have sat in between entrepreneurship and the startup world and the big industry side and tried to bring the two together. So where that interface can be kind of rough, where it can be difficult to get traction, that's where I try to focus my attention. All right, so this is what I hear a lot in San Francisco, in Silicon Valley, where I'm from. I am going to disrupt healthcare. My diabetes app will cure diabetes. And I have to say the bad news is, no, you're not. I don't want to quash your dreams, but the reality is the size of the United States healthcare system is even beyond imagination. The GDP of Germany is 3.4 trillion. The national health expenditure that's projected in the United States for 2016 is basically the same number, 3.2 trillion. Nobody wakes up and says, I'm going to disrupt the economy of Germany today. And if they did, I think Angela Merkel would have something to say about that. So it's a similar thing when you say, I'm going to solve all the healthcare problems. So what should you do? You should find your niche, understand where a problem you can solve is, and engineer yourself to take advantage of that opportunity. I'm going to tell you how, at least a start of it. And this is desperately needed. You all know all the bad things that happen when you have a sick care system rather than prevention, when you spend way too much to get very poor outcomes. But the most important thing that makes this a pressing issue today is that the most recent projections show that millennials, generally people around 30 years of age, a little younger in the US, are going to spend 1 cent out of every 2 cents, half their incomes, on healthcare over their lifetime in the US. That's crazy. That's crazy. They're basically slaves to our healthcare system. So who are these people? Well, in some other somewhat potentially more rational countries and systems, you have a government that provides for healthcare or sets certain rules, or you have a set of hospitals that you can identify as a potential customer for your solution. In the United States, we have several players, some of them aren't even healthcare specific, who are involved in the payment stream, how money is moving around the system. And in this fragmentation, that's where you can find the opportunity. So let's start at the top, the payers, private health insurers, at all different levels, national all the way down to just the size of one city or municipality. The regulators, the federal government does absolutely have a very strong role in healthcare in the US, not just to set rules and approve drugs, but also to determine certain units of coverage, how the things that all the private entities are doing are going to be ascribed a unit for payment. So they may not pay themselves, but they're determining how things are getting paid. Very important point. On purchasers, those are the people who buy healthcare for others, employers. We're going to get to them in a moment. We have suppliers, drugs, devices, imaging, labs, diagnostics that are things doctors and hospitals use to provide care. And then spenders. So we noted that employers spend $600 billion. But who else is funding all of this through various mechanisms like taxation? The average American is spending $1,000 out of their own pocket on healthcare. That's even if they have private insurance, by the way. And also the Centers for Medicare and Medicaid Services, that's CMS, which is funded by taxpayers, it's part of the federal government, is spending a huge amount of money for our two public safety net programs, and also there are taxes levied on all these private entities that specifically are designed to fund this system. All right, employers, what am I talking about? So one of the strange things that happens in the United States is you get health insurance through your job. For 61% of Americans, they receive their private health insurance coverage from their employer. And this is a bunch of reasons that are on this slide. I'm not going to go into them. It's part of corporate tax policy. It has a history coming back from World War II. But the bottom line that you need to understand is half of those Americans, their employer is making certain decisions which affect their healthcare access. Amanda, you must be kidding. That makes absolutely no sense. And how on earth could American companies pay for this? I don't know. I'm not an economist, but they do. And the interesting thing about it is that employers have actually been absorbing the majority of the healthcare cost increases. We've heard for years that healthcare cost increases are trending upwards, 14, 15, 16% every year. But it's hitting the average American, one who has a job and is receiving health insurance through that job, only in little tiny increments. Employers are bearing most of this cost. And there, down on the bottom line in 2015, you can see that the contribution towards a premium that an individual is making from their paycheck is just shy of $5,000. That's for their family. But the employer, for each individual employee, is spending $12,000 a year, in addition to what they're being paid. So this is weird, right? And this must affect the entire system in the US in a very specific way. Well, it absolutely does. The first thing that happens is if you lose your job in the US, you lose your healthcare. It's bad. You might have a great idea to start a company. This is the land of opportunity, right? You might be an entrepreneur, and there are serious disincentives to quit your job, because what are you going to do for health insurance? On the open market, it can be very expensive, although some of that has been fixed by the Affordable Care Act. The time horizon for decision-making is 1 year. Employers are thinking about this in 1 year budgets. Insurance companies are thinking about this in 1 year. Hospitals are contracting with payers in 1 year increments. Also, the employer chooses the health plan, the private commercial insurance. The health plan chooses which doctors are in that plan. The doctor chooses how to treat you, and all of these rules are opaque to the patient. And we have no tool that lays all of these out. These are all private business contracts between individual entities. And then also we have significant market power over our most powerful hospital systems. So really big names everybody's heard of all over the world: Mayo Clinic, Cleveland Clinic, Stanford, Partners Healthcare, which is the Harvard teaching hospital. They can command very high prices on the market from these private insurance plans, which then pass the cost on to consumers. So you're starting to see how all of this piles up, right? It also means that employers buy something other than insurance. They buy, this is where you come in, they buy solutions to help them keep their employees healthy and productive. So what are these services? They buy administrative services. They tell me how I can have a very efficient provider network of the best doctors. Tell me how I can keep my employees from going only to doctors in the network so that I can keep the cost limited. Tell me how I can send messages to my employees about how to keep themselves healthy so that that cost is not very high. And navigation and assistance tools. If you make a change to healthcare access, you need to tell your employees about it. We've made a change to your benefits plan, and you are no longer able to get gastric bypass surgery. You need to understand why that is and how you need to appeal if it's medically necessary. And so all of those tools are things that an employer would buy on behalf of their employees. So why is healthcare broken? And this is, what does not earn me any friends and imperils my ability to get a job in the future in my own industry. Because my answer is everybody. It's everybody. There is no one evil actor, although sometimes politicians would have you believe otherwise. There is no one player in the healthcare system who, if we could just get rid of them in the night, everything would be fine. It's everybody working together in a system that has a lot of cross incentives. And everybody's trying to do the best they can in the system that they have inherited, but it just keeps getting more and more complicated. So hospitals set their own prices. If they're those sort of big name hospitals that I mentioned, they say how much they want to be paid. They operate like unregulated utilities. They are the supply of healthcare, but they are unregulated. Physicians, the more I do, the more I get paid. That's what happens when you are a private citizen. You are not an employee of the government or of a healthcare system. You are Dr. Goltz, and you've put out your shingle, and you do as many procedures as you can, and you make as much as you can. Insurance. Private insurance means, especially if they're a publicly traded company, their responsibility is to generate value for shareholders. Nobody ever asked them to take the role of guardians of healthcare for a society. That if you have a system in which health insurance is a private enterprise, this is what you get. Brokers, they sell insurance plans on a percentage basis, so they want it to be as expensive as it can. Pharma, life sciences, biotech, I have to protect a 10-year research and development pipeline for my drugs. I have to protect the investments I'm making, and I need a return on that. Ancillary services, things other than hospitals, hip replacement on demand, urgent care centers. As it gets more and more expensive and access starts to drive down and down, these separate facilities that are not quite hospitals but providers of additional care, they jump into the fray and they start providing services as well at the highest dollar they can command. And finally, the consumers. If you don't pay for it, because your employer is paying for your insurance and your insurance company is paying prices you don't even understand, why on earth would you have any financial interest in your own decisions? You expect maximum choice in the United States. I want to go to any doctor I want, and I want the highest quality and instant service for free. All of these working together gets you to $3 trillion. So what's changing? Here's the opportunity part. Everything. We have payment reform. We have 1,000 experiments that are changing all of these relationships and disrupting them. And people are looking for solutions to convert to a new system. So what's the trend? Well, today is the mess I just described. Tomorrow, we're going to move care out of expensive hospitals and expensive settings to wherever the patient is. That's where we get telehealth initiatives. We're going to start paying for value. We're going to start measuring outcomes. We're going to focus on the consumer and consumer choice. We're going to try to make them understand what efficient, effective, high-quality care is and encourage those choices. And we're also going to move to outcomes. And I want to talk a little bit more about that in a moment because it's a passion of mine. So what are physicians and hospitals looking at when they're tasked with undergoing this transformation? And what are they looking for in terms of solutions to help them do this? You know, they're good at taking care of people. They're good at healing. They're not great at transforming their business. So as costs continue to rise and hospitals and physicians are being squeezed on profit, they can only make a profit if they work together and they start thinking about the entire patient experience. Also, we're having some mandatory programs that change how they're paid. You get paid on 45 days of an episode payment around a particular procedure, a coronary artery bypass graft, a bypass for your heart, for example. Used to be you were paid for every drug, every night in the hospital, every tube, every catheter, every trip to the bathroom. We're getting rid of all that. We're just saying it's this amount of money. If you can fit care into that price, good for you. If you overspend or you mess something up and the patient gets sick and has to come back, very bad for you. And that's something that operationally, technically, engagement-wise, hospitals don't know how to do. And they're looking for startups to help them do that. We have hospital-acquired conditions reduction, an amazing thing that happened to me, and I'm dating myself, but when I first started to work in a hospital system is if a patient came in and they needed a leg amputation, and something happened, something went horribly wrong, bad signal was passed from one team member to another, nurse wrote something down wrong, and the wrong leg was cut off, and the patient had to come back to have the original leg cut off, now they have no legs, the hospital got paid for both legs equally, for the error and for the proper procedure. We didn't change that until 2007, by the way. So we've learned to get better, and the pace of payment reform is accelerating. And now we've decided we will not pay for bad things that happen in a hospital. If you are given an infection in a hospital, we're not going to pay for it. But that means hospitals have to redesign how they do things. Accountable care organizations and patient-centered medical homes. Way too much to talk about here. You can Google those terms and learn about them if you think that that's a model where your product has a niche. But they're new ways of designing care around the patient. And so here on the other side, I'm not going to read them all out, but these are specific capabilities that hospitals are looking to purchase. And there is a large health IT environment in the US, but there really aren't specialists in these. They're popping up now. So there's no dominant player you will have to dislodge. The best product is actually going to win. So patient-reported outcomes measures, I wanted to come back to this because I think it's a really big deal, and I think that people talk about it a lot. There's actually a great deal of science to leverage around this, and I think it's the next big opportunity. Because here's the problem when you change your enormous continent-sized healthcare system. You have to redefine what quality and effective care is. You've been measuring how many dollars you spent. Now you got to measure how healthy people are. How do you do that? So we're building a measurement system called patient-reported outcomes measurement. We're actually trying to figure out what happened after we cut your leg off and sent you home. So a patient-reported outcome is something like depression, or better functional status, ability to walk, or relief from pain. The measure, the PRO measure, is how you measure that in a scientifically valid way. So there's actually a standard question where you ask the patient gives you a response. Over a population, it's a reliable answer. The performance measure is when you take that measure and then you actually make it something that a hospital is paid on, that can be measured hospital to hospital, and you can actually set a payment system on. So other countries are way ahead of us on this, but we're developing our own anyway. We really don't like thinking about healthcare rationing. That is anathema in the United States, a bad term. So we try not to think about the effectiveness or the value of the procedure in return for the functional status that you get out of the patient. Instead, we just want more better all the time. So where, for example, the British system uses quality-adjusted life years, we don't do that. We're using individual measures for each individual condition. And in fact, this is now the way the CMS pays for depression relief and treatment in the population over 65 years old, which is our Medicare program. There is a CMS measure, and if you, as a doctor practice, does not score well on this measure, you will not get an additional payment. So starting to be money behind it. A couple more facts on PROs, because I actually am sort of encouraging all of you to either accommodate for this or try to think about business solutions that deliver patient-reported outcomes. Pharma and life sciences develop them as part of the proof of efficacy of their drugs in FDA trials. Hospitals develop them for clinical research, so sometimes you can take advantage of the measure of development, having been paid for by somebody else. And the opportunity here is for sensors, devices, anything where the patient doesn't have to submit to an interview or write on a patient questionnaire. Maybe you could just pick up functional status through a device that senses motion, for example. All right, so that's hospital and employers. Now what are hospitals and doctors. Now what are health plans and employers looking for? So then they're the ones who just shell out a ton of money, but aren't even necessarily in this industry. So they have very few controls over what actually happens to the patient, but they pay for all of it. So how do they shift? Well, insurance companies tend to be big. They have a lot of things on their mind, and they can't control what the doctor does. So they want to focus on problems that are very large in terms of dollars, and they want solutions that are very broad across their problem. And if you guys remember the comments made earlier today about, are you a business or are you a product? This is where this really matters. Because if you are just a product, it's going to be very hard for the health insurance company to pick you up and spread them across their enterprise. But if you are a business partner that they can work with, if you've proved that your system works, that your product works, that you can engage patients and individuals, and if you know exactly how you will deliver value and you can chart that out, you're a lot easier to work with. So health plans are looking for ways to improve the economic story, how to drive accountability, to make sure the right things are done at the right time on the right patient. But they're allergic to things that are very expensive but only affect a small amount of patients. So if I had a startup that I wanted to sell to a health plan, I would focus on these 5 things. These are the top 5 things that are the most costly for employers. We call it stop-loss insurance, but these are catastrophic things. There are no surprises here, except for 2 of them are related to maternity. You think about it, maternity itself, the glorious act of giving birth, the miracle of life, is a nightmare cost problem for a health plan because one person just became 2 with all their attendant medical cost. So that's how a health plan thinks, and that's how you would think too if you were in that business. All right, other opportunities. So health plans now have to talk to individuals in a way they've never had to before. How do they do that? If they can't design a product that is something anybody would want to use, can you help them? Cost shifting. How do you make consumers care? How do you incentivize them to make good decisions when they don't bear the cost themselves? How do you move as a business from 150 years of managing risk? So the company I used to work for, Aetna, was 150 years of designing perfect actuarial tables that could tell you exactly what a person, based on basic facts of their life, what their medical costs would be. All of a sudden, that's gone out the window because I'm now in a totally new system where I have to care about people's outcomes. And people's outcomes are very multifactorial. They depend on a lot of things I can't predict, right? And I have to add services to my therapies. It's not just paying for units of care in hospital, but making people healthier over time. So health plans are looking for tools to collect data, analyze, dashboard, measure, report. These are the primary functions. And my encouragement here is that your company should be prepared to do at least most of the things on this continuum. If you just slot in with one, you're asking your customer to find partners to do all the other pieces along the continuum with you. That's very hard. At least have a sense of how you're going to cover sort of the wide range of all the tools a plan would need. More opportunities. So I'm gonna skip the today and tomorrow, but I am going to talk about 3 successful experiments that I had a hand in at Aetna, 3 startups that Aetna said, this is really great. We love your solution. We're going to channel you through to our millions of covered lives. One was a very popular app on the App Store called Dhd16, made by a company called Wildflower Health. It was a popular pregnancy app. I'm pregnant. I'm very excited about it. I want to be social about it. I want to understand what I need to do for a healthy pregnancy. I download this app. We worked with them to say, do you have Aetna insurance? Yes. Did you know there's a program that we would like you to enroll in? Because this Aetna program actually helps mothers have healthier pregnancies. You get a nurse you talk to on the phone. You get all this very useful information. You understand certain clinical guidelines that discourage you from unhealthy behaviors like smoking and things that lead to prediabetes or gestational prediabetes, and discourages you from having early inductive C-sections inductions in C-sections. If you don't know what these are, there's a big fad in the US for having a scheduled delivery. Even when you don't need it, baby's not in distress, you're totally healthy. It's just you really want to know when you're going to go in the hospital. And your doctor, who may or may not have a golf tee time later that day, definitely wants to know when they're going to deliver you. So they schedule it. And also early inductions. When everything's healthy, everybody's going well, but they just decide it's time for baby. And they put you on a drip and you deliver early. Totally unnecessary, somewhat dangerous, unfortunately, highly lucrative. So to discourage those, we put this program in place. We couldn't get people into it at Aetna, because here's the thing. When you become pregnant, you don't call your health plan and say, I'm pregnant. It's the last people you tell, right? Your insurance company. So by using this app, we picked up women very early in their pregnancy. We sent them those healthy messages very early. They had healthier pregnancies, and the results were much better, both in quality of care, in the actual outcomes for mom and baby, and the cost was much lower. Where is your pain? So we have insurance coverage for about 20 hours of physical therapy. Sometimes that's enough, sometimes that's not. Depends what kind of surgery you're recovering from or what kind of problem you have in the first place. Problem is when the benefit runs out, you may need more, and you get a letter from your insurance company that says, sorry, no more coverage. You're going to have to pay out of pocket or you can't have more physical therapy. So why not just deliver it at home for free? Especially when it's really hard for people to take time off and drive to physical therapy. And so sometimes they miss it, and that's one of their 20 hours down the drain. So we delivered it in a web-based format. You could do it at home with simple objects you have in your house generally. You wrote a report about how you were feeling. The doctor overnight adjusted your plan, and you got a whole new set of exercises the next day. Fraction of the cost, exactly the same benefit. Then finally at the end, it's a company called Nutopia. We have an obesity issue in the United States. About half of Americans are overweight, a third are obese. I'm probably contributing to that problem. But the issue that we were trying to solve is we were trying to engage people in something that's very hard to do. It's something that I refer to as the cake is delicious today, diabetes hurts tomorrow problem. That's the way the human brain thinks. I want to do this thing that will give me pleasure today. There are going to be consequences tomorrow, but my brain is bad at changing my behavior today. So we put a program online, told people about the likely causes. We put in a genetic component. Not quite sure of the science behind that, but I will say that it's very engaging to hear that you have something from your genes that causes you to be overweight. It actually makes you deal with it like a disease instead of like a bad habit. That actually gets people to change their lifestyle more quickly. So all of these things are digital. None of these were developed at Aetna. They were all startup entrepreneurs just like yourself. And because the solution was delivered as a whole solution, the company acted like a business, and because we believed in the ROI, we were able to adopt them. What do consumers want? I get asked this question a lot. And I'm always very nervous because it's usually a doctor or a health plan executive or the president of a hospital who is asking me. And here's the problem. Consumers don't want to be sick. They don't want any health care. I don't want to be sick. I don't want to think about this. It's a nightmare and it's awful. And it's going to be expensive and I'm going to feel bad. And if it's a chronic disease, you're telling me I'm going to be sick for the rest of my life. This is terrible. The issue here is that engagement is really hard. You could design a beautiful solution that works really well to make people make good choices in the healthcare system and take care of themselves at home. And if nobody does it, it's not a good product. It's not a good company. So you have to be very clear and sure about how you're going to engage consumers to do what you want them to do. So pop quiz, Professor Brown already gave us the answer earlier for those of you who came to that fireside chat. But what is the most successful healthcare app to date? It is, of course, Pokemon Go. It's not a healthcare app at all. Why is that? Because I don't want to consume healthcare things. I want to do things that are fun. And the definitions of success in app sense are engagement with 7.5 million downloads, with more daily users than Twitter or Tinder. The outcomes, exercise was tracked. There's actually a study going on to track reduction in anxiety and depression because it's inherently a social activity and it gets you outside. And monetization, Nintendo shares are up 120%, good for them. There's $3 billion in additional revenue from in-app sales, $3 billion to Apple. That's just iOS. So when it hits the rest of the world, Android comes in, those numbers are going to be even bigger. So more opportunities in the customer experience. What are the features that people actually want? Not what health plans and doctors think they want, but what do individuals actually want? Well, I want to know how much it's going to cost me out of pocket, but only if it's accurate, and this is really hard because nobody can tell you what the doctor is going to do to you until you actually go see the doctor. What tests do I need? What procedures do I need? Is there a complication that'll cost even more? So this is a tough puzzle, but you guys are smart enough to solve it. Simple access to my health record. That would seem easy, except remember in the United States, we have 300 different electronic health records companies, none of which talk to each other. I want mobile post-care instructions and follow-up notifications. Was I supposed to pick up that prescription? How often was I supposed to take the drug? When do I unwrap the bandage? It's puffy and bleeding. What should I do? These are all solutions that people are looking for, particularly when they start to be paid based on what happens to the patient after discharge to the hospital. I want to be able to make appointments online. I want it to be like Uber. Why is it so difficult? And why is the nurse so mean to me when I call? An essential payment portal to payers and providers. So we already went through how all these people are chipping into a healthcare pot. How do I manage that money? We have a health savings account, which is a tax-advantaged financial instrument in the US to help people save for healthcare costs. It's so difficult to track, but those of you who have experience in fintech can sort of bring some of that learning here. What do they care less about? Wearables, where the data doesn't really go anywhere, diagnosis tools that tell me at the end of the day I have to go see the doctor anyway. It's really about management and less about the diagnosis and clinical piece. And I think we can take some lessons from our friends who have done this right. Amazon, if I need something and I go to Amazon, I know I'm going to get it. I know it's reliable. Communities, everywhere, but particularly so in the US. Vanguard investments, very easy online tools. I am not great at investing, but this company helps me understand exactly if something is risky or conservative and what I should do. And quality control, FedEx. I send a package to FedEx, I type in the number, I see it travel around the world. I would love to track and care this somewhere. And then a quick note on behavior change. We haven't really found anything that solves the cake is good today, diabetes is bad tomorrow. We think some hope from AI. AI is going to think about the conference. We think there's a way to automate your mother's nagging and couple it with GPS location. I see that you're at McDonald's, Amanda. Don't make that right turn. I told you not to turn right into the drive-thru. That might be really helpful because timely reminders actually can take are really what are effective. Last word, and then I'll take some questions. We've talked a lot about ROI. It's very slippery and difficult to define in healthcare. If you are a good person, you want to say it's helping people be healthier. Unfortunately, in the US, that's called a nonprofit. That is not a company. Here's how you have to generate value in the US healthcare system. You have to have immediate improvement in revenues for your healthcare stakeholder, either by decreasing what they're spending or increasing what they're getting. Or you have to generate, or preferably both, demonstrable, repeatable, significant short and long-term cost savings. Take something that's really expensive because it's a bunch of waste, make it less over time. What's not ROI, but is good, but not ROI, engagement, value-based care, better outcomes. I see that over and over again from the startups I work with. None of those things are business reasons to buy. It's really the stuff on the left-hand side. And so that's me. That's my personal information. I have a commitment and mission to help companies solve some of these problems. I'm happy to do it. The reason you see Captain Jean-Luc Picard there is because I'm a giant Star Trek nerd. Only Next Generation. I don't like the other ones. But he's carrying that thing there. And that thing is from an episode that aired in 1990. And it was supposed to be his super futuristic Star Trek tablet computer. It's kind of like the size of a suitcase. I don't know why it's folded in the middle and it's super weird. So right now we have something an eighth the size of that, which is infinitely more powerful. So you always underestimate the change that can happen in 10 or 20 years, while we overestimate the change that can happen in one. Try to get the sweet spot in the middle there. That's it. U.S. healthcare.
I mean, probably go on with questions if I remember. And just bounce to the page. I mean, you're going to do an interview as well.
Yes, I am.
But do we have a short question from the case just?
Yeah, I have one quick, I just want you to elaborate on something, because one thing, this is a European conference, and we have a lot of people online from all over the world, and one thing that I don't think everybody understands that we need to really say is how great American healthcare is, or the best, let's say government healthcare, the speed, the affordability. Can you break that down in a couple of minutes just to explain?
So you mean specifically like the program you had for federal employees of the government?
Yes.
Okay, yes, absolutely. So if you work for the federal government, not the state, but the federal government in the US, you have access to a program called the Federal Employee Health Benefits Program.
I think so.
TRICARE. I brought up Mole, a friend of mine who is actually the brains behind this whole operation. But yes, so that program is the federal government purchasing benefits for all of the employees. It is delivered through some of the private entities that we've discussed, private hospitals, private doctors, but because the federal government is enormous and has a fair amount of bargaining power, they can crush costs down in the system, and they can also demand certain availability and access that smaller private companies cannot. So when you receive that healthcare, which is the gold standard, it's absolutely right, you're getting the best of the private academic research, cutting edge healthcare at the lowest cost the government can buy. When you hear some political platforms in the US about single payer, they are sometimes talking about that. Another version is Medicare for all, which would mean we would preserve the system mostly as it is, but everybody would receive what people over 65 years of age receive now, which is that the federal government would use that bargaining power to lower prices. And so, you know, I think, frankly, both of those political positions are untenable at the moment in the climate in the United States. But I do think that the seeds that we have sown through the Affordable Care Act, the many payment reform experiments, are going to try to drive to a model that gets closer to that, because it really does come down to how do we aggregate volume, to take cost out of the system, which is essentially what the bargaining power of the federal government has done.
Yeah, and I mean, a great example of that would be like...
Elizabeth, we need to go to the next speaker because we have another announcement here. I'm sorry. But we continue that discussion here with the interview thing there. Sure. Thank you. Amanda Goltz, thank you.
Take care, Ray.
Would have taken the same...